Hello, I'm Lowell Kabnick. On behalf of Anil Lymphatic University, I bring you our grand rounds every Wednesday, and I'm delighted to have Joanne Lohr talking about compression, oxygen, humidification, improves venous wound healing, and reduces venous ulcer recurrence. Thank you, Joanne. The floor is yours. Then followed by Tom Maldonado and Anil Hingorani as discussants.
Thank you, Dr. Kabnick, for that introduction. Trying to get this to open. There we go. All right. Can everybody see my screen?
Perfect.
All right. So I have to disclose that well, that I work for the VA, and nothing I'm going to say is represents the government or the Veterans Association. Now, for some reason, I'm having trouble advancing my slides. There we go. Again, I'm talking on my own. We're going to talk about the integrative treatment and approach to address the key drivers of wound chronicity and wound healing. The common pathophysiology of wounds, we all know it's a self-sustaining cycle of hypoxia, edema, and inflammatory changes. And this can be compounded by bioburden, ischemia, reperfusion, injury, comorbidities such as diabetes, venous insufficiency, cardiovascular disease, and obesity. So the inflammatory wound environment is characterized by increased vascular permeability, persistent edema, tissue hypoxia, accumulation of pro-inflammatory mediators, and an increasingly amplified inflammatory signaling. This creates an environment that is favorable for biofilm formation and infection, and these will then sustain the inflammatory response and impair wound healing. Wound repair is impaired below 30 millimeters partial pressure of oxygen with a critical threshold of 20 millimeters of mercury, where the cells switch to an anaerobic metabolism and the oxygen-dependent processes will fail. Oxygen levels at wound centers are commonly below 10 millimeters of mercury, and I do mean the center of the wound. The physiologic healing occurs between 30 and 60 millimeters of mercury, while the supplemental wound healing occurs above 60 millimeters of mercury and enhances enzymatic activity, immune defense, collagen synthesis, and angiogenesis. Now, this is a very complex slide, but basically this shows you the interrelated cycles of wound healing and altered self-sustaining feedback loops that encourage and maintain the inflammatory response. So what are the barriers to healing? Prolonged inflammation, edema, and lymphatic insufficiency. This also will cause increased pain, and if you can get rid of the pain and the edema and the response, the pain scores go down and the patient's compliance will actually go up. Tissue hypoxia, bioburden and infection, the systemic issues, and then repetitive trauma, shear, and environmental pressures, the ischemia and reperfusion injury, and a moisture imbalance, which can lead to mastication and desiccation. So the inflammatory resolution is critical in the process of wound healing. You have redox signaling, endothelial cell activation, and pro-resolution mediators and synthesis. These are oxygen-dependent and mechanical sensitive. Lymphatic clearance of the pro-inflammatory mediators is critical. This is driven by the mechanical forces movement, as well as edema management, oxygen-dependent, and again, mechanical sensitive. Tissue repair is critical to the process. You have pro-repair macrophages, phenotype switching that is driven by the inflammation, the redox signaling, the upregulation of growth factors, and the pro-repair of mediators. Again, oxygen dependent and mechanical sensitive. Collagen synthesis and angiogenesis, epithelialization, and remodeling are driven by the M2 macrophages and the signaling complex. Again, all of this is oxygen dependent and mechanical sensitive. So therapeutic approaches address all of these layers of wound healing and issues, hypoxia, inflammation, and lymphatic dysfunction. So by creating and integrating oxygen delivery with cyclic compression, ITOTI addresses multiple interrelated barriers to repair, promotes durable healing, and reduces the complications. So multimodality therapy really works. Again, the topical oxygen results in elevated tissue oxygen levels, reduced infection, elevated VEGF and TNF and I interleukins. It will increase your angiogenesis. It increases fibroblast proliferation, gives you improved granulation tissue quality, better collagen organization and cross-linking for durability, faster wound contraction and epithelialization, and a stronger, improved wound healing overall. The mechanism of actions there are listed on the left. So what happens when we do intermittent compression? We see, again, reduced edema, decreased pain scores, and improved patient compliance, reduced inflammatory changes, increased perfusion, upregulation of VEGF and nitric oxide, improved granulation tissues, improved fibroblast and vessel density, better collagen fiber organization, improved limb salvage, and wound healing overall. So again, you can look at the mechanisms on the left there. The clinical findings for multimodality therapy result in the end of higher incidence of healing, reduced time to healing, and reduced infection. There's improved granulation tissue quality, pain reduction, and compliance are huge. There's improved quality of life scores, reduced scarring, lower recurrence rates, decreased hospitalization, and decreased amputations. And again, this is the way the multimodality interacts with the inflammatory wound healing mechanisms. So this study evaluated the effectiveness of a unique multimodality therapy with combination therapy, looking at the treatment of chronic lower extremity wounds. This basically fills a huge gap in the biggest other trial that's ever been reported was only 202 patients, and this will address the current defects, and there were no large trials prior to the study. We looked at diverse ulcers. We included 72% diabetic foot ulcers, 20% were venous ulcers, 7% were kind of a mixed wound ulcers. They were complex and had been hard to treat or were not responding to treatment very well. This is from a large retrospective database that was analyzed. We did start with over 5,000 patients and eliminated those that didn't complete treatment or were in the process of treatment from analysis. So again, topical oxygen effects improved the microbial defense, increased angiogenesis, accelerated epithelialization, activation of the anti-inflammatory markers and pro-resolution markers, the cyclic compression effects you can see there, and then the ultimate result is what we want to see, and that's the final wound healing. So again, this multimodality therapy can be used on full thickness chronic wounds or acute wounds that might be at risk for delayed healing. It's a 60 to 90-minute cycle. It can be applied over gas permeable dressings, and it can be applied simply by the patient or his caregiver, or if he's in a assisted living with some of the people as the residents. It's in-home, and the setup is explained, and there's support provided. So again, it's a great therapeutic intervention. And again, it doesn't take away the routine wound dressing changes. It's applied over any gas permeable dressing. And it's recommended for 90-minute treatments 5 or 6 times a week. One of the defects in the study is a lot of these patients were from the VA. So there's a small group of females, only 10%. Patient age and years was about 69 to 70. The pre-treatment wounds have been present for 7 months, and some patients had more than one wound. And so we had kind of a variety of things that we were treating. If we look at the results, The complete wound healing for the entire group was 64.8%, which was our primary endpoint. The mean time to closure was 4.2 months, and this was even though wounds had been present for up to 7 months prior. The retreatment rate was 2.7%, and these patients, for the most part, have been followed up to almost 14 months. The hospitalization rate was 3.7%. Previously, hospitalization rate was reported as up to 40%, and the amputation rate was 6.1% versus the historical control of 20%. And here you can see the wound healing, the type of ulcer, and the categories, the duration they were there, and the time to heal. It's pretty amazing that you could get diabetic foot infections healed up in 4.2 months, and the venous leg ulcers in 4 months. The purple is the percentage of these wounds that we were able to heal. Cox analysis, this is the pretreatment wound age, wound type, and number of wounds each patient had. And these were significant indicators of the probability of wound healing. This Kaplan-Meier curve shows arterial and the likelihood of wound closure by etiology. And here is the cumulative closure rate for patients who had multiple wounds. The women tended to heal a little faster than the men. So the big thing that happened in this study is that the healing rates were much higher than we expected in both the diabetic foot ulcers and the venous leg ulcer groups. In this study, we had a 4.2 month duration to healing with a 3% recurrence rate, retreatment rate in diabetic foot ulcers versus the 45% in the previously published literature. Venous ulcers in this study healed at 4 months, 72% of the time, versus the historic control of 57%. Here's a couple of examples. Diabetic foot ulcers, pre-therapy at week 12 and at week 20. The venous leg ulcer, pre-therapy, and this ulcer had been present for 5 years previously at 12 weeks and at 14 weeks. Here's an arterial venous mixed ulcer, pre-therapy at week 6 and then at week 10. So you can see it really does work. We started out initially using this only on patients that we had given up the potential to even heal anybody. This is a surgical and kind of venous ulcer patient. Again, the pre-treatment, started therapy treatment at 4 weeks and then at week 6. So again, these complex wounds benefited more so than even the simple wounds. Earlier treatment predicted better wound healing and faster rates. The durable healing rate exceeds the normal standard reported data. And these retreatment rate of only 2% at 14 months is consistent with the improved cross-linking we see with the higher oxygen levels in the deep tissues. And there are still some gaps in therapy. So this was the largest multimodal therapy group published to date. The healing rates exceeded the population benchmarks despite the greater complexity of our wounds. This was actually consistent in findings across all of the wound types, no matter what the ulcer etiology or duration were. And the durable healing rate and low complication rates make this an attractive therapy. It's also attractive to the patients. They become almost addicted to it and don't want to give it up. So this, again, is the real world comparison, the healing rates versus the wound registry. And you can see the great success we had here. I would encourage anybody that has a difficult to heal wound to try this because it really does work. And it's amazing, period. Patients, even when they're healed, want to continue therapy. So with that, I'm going to stop and let the discussants weigh in.
Thank you, Joanne. Appreciate it. Tom, what do you think?
Well, I mean, that's really amazing, Dr. Lohr. I think that's the data. First of all, just the robust, number of patients you have enrolled, and that's the beauty of these VA studies, after all, right? Because not only are there a high number of patients, but what you probably also are familiar with is you have a very compliant patient. So as far as follow-up and leakage from the system, we don't have that in the VA studies. We're able to really contain all that and get great data that way. So I think it's a really nice study. I think that, a lot of these mixed ulcers, I was going to ask you about the arterial, because although it's only 6% of the patients, those can be really tricky and sometimes require prior intervention to improve arterial flow before you can address it. So what's your algorithm in this study? And specifically, are those patients who had the arterial component addressed before or concomitantly, or how did that play into that?
Well, a lot of times patients will have wounds that are chronic and are not recognized that they're ischemic. As soon as their ischemia component is recognized, that's treated, at least in my practice. The problem is this is a retrospective database, and the one thing we're lacking is the relationship of revascularization to the arterial group. And so we've started collecting that data that was not initially collected as part of the first data registry.
Right, because I think it's an interesting question, because sometimes there are arterial patients who I find it's easy to say, well, fix their inflow and get the arterial flow better, but sometimes it can be very complex and it requires a distal bypass. And if we can avoid that, because you can show us that when you look at this cohort, maybe forego the distal bypass and just treat him with this oxygen compression therapy, and that might be a real opportunity,
So for us venous experts, Tom, what do you think?
I think it's great. I think it has a lot of promise, and I think I'm kind of interested in using it. I have to confess, I don't have a lot of experience with this, although I've heard you talk about it, and I'm familiar with the paper. I think that it's also interesting, it's the problem with wound studies. I think I'm curious to see what Anil has to say. And Lowell, it's multimodality, right? You have many things going on at once, so it's hard to tease out what exactly is having an impact. But I think it's really exciting stuff.
I think you just hit the nail on the head right here with multiple modalities, different approaches to wounds, and which comes first and which is additive, et cetera, et cetera. So we're still trying to figure that out, even though years ago we tried to decrease ulcers by 50% 10 years ago. I'm not sure we're there, and especially understanding the venous wounds and what makes them tick. Joanne went through a lot of that, and thank you for that. Anil, floor is yours.
So as Joanne said, we started using this in patients we had tried everything and given up, and we had positive results. And it's not meant to replace your standard therapy. It's really meant to be an adjunct, and that's where we found it to be the most useful for any type of ulcer. One of the first things that we noticed that when the patients actually start using it, the tissue edema starts to resolve, and I think that's part of the reason why they heal so well, either in arterial venous or combined ulcers.
Is that local tissue edema?
Yes, exactly. Right around the wound, when you start to see the edema resolving, then you know the patients are actually using it. And another thing that Joanne also mentioned is that the pain scores start to fall off. So patients who have a pain score 8, 9, 10, and they start to say, my pain is better, and then they get hooked because now their pain is better, and you know that they're actually using it. I had a question for Dr. Lohr, however. One of our major challenges is getting the authorization, getting the actual authorization from insurance for this. Which patients are you able to get them on the therapy, because it can be challenging?
Well, this is one of the blessings of being at the VA, because this is approved for the VA. The big issue is getting CMS approval and getting approval through the regional carriers. And hopefully this study and this outcome will help improve us and facilitate getting carrier approval and getting more widespread use.
Anil, one of the questions that I have for you and Joanne and Tom is the fact that we know that if we do early intervention in venous, that does heal wounds very well, and the adjuvant of using drugs. Where does this really fit in? Does this fit in before, after, during? Joanne?
Well, again, I think it goes back to kind of the point Tom was bringing up about the arterial stuff. As soon as you recognize there's an underlying pathophysiologic problem, whether it's reflux in the venous ulcer, I think that once you maximize what the patient will tolerate, you should be fixing an etiology, because it also make your recurrence rates better.
Anil? Well, how do you use it in your practice for venous?
We use it for patients that we've already maxed out everything else. We can't use it at the outset. New York State doesn't allow it. So New York State allows it not only for the VA patients, for patients who are in government programs such as the Indian reservations, but also we can use it for Medicaid HMOs. For us, that's been our largest segment. So we're fairly restrictive. Patients have to have failed other therapies before they and have to have been followed for a number of weeks before we can initiate this therapy. So we use it after we've already sort of maxed out everything else.
No, thank you for that. Tom, where do you think we need to look at in terms of a study in comparison in venous ulcers using topical oxygen therapy, etc., hyperbaric?
Yeah, I mean, this is good foundation, right? Retrospective, big, large scale study, but obviously the next step, and I think would be most impactful, is a prospective study, even a comparative cohort with another alternative, with and without the oxygen therapy. Obviously, as Anil said, we kind of throw the kitchen sink at these patients. We give them everything we can, including interventions, compression, treat their lymphedema, look for central occlusions or stenosis, May Thurners. But I think the more we can control for those variables in a prospective way, I think that's going to be what's going to be the next step as far as impact. So,
Where should we be in terms of comparisons? What should be our standard? Should it be
yeah.
intervention and then with or without?
Yeah, and I think, yes, I agree with that. That's how I would approach it. And I would also try to tease out a much more refined cohort, maybe the post-thrombotic syndrome patient or someone who has a prior history, because, as Joanne said, this runs the gamut of mixed arterial and lymphatic and venous. But if we can tease out a specific cohort that is more definable, it would also be helpful, I think. So maybe looking at the post-thrombotic syndrome patient, patient with history of DVT, occlusive disease, as a defined target.
Well, that's
I also,
helpful. Go ahead,
I just wanted to say, I also think that it's very helpful in patients with small vessel disease when you've totally maxed out everything else you can do. And so I think that for diabetics and for renal failure patients, it has a special place.
So sticking back to venous issues, AJ Kahana asked a question, is it better to have topical oxygen therapy or better with hyperbaric oxygen chamber? Do we know the answer to that?
Well, my answer is I can't get patients into a dive chamber, and a lot of my veterans won't tolerate going into a chamber, and we don't have one available. So this is what I have easily available, and so the hyperbaric chamber to us is pretty much for the most part non-existent.
Anil?
Plus, yeah.
We have both available to us. We're somewhat fortunate. But the reality is that for many of our VLUs, they're not approved for hyperbaric oxygen. This is done at home. It's approved for VLUs. It's cheaper. It doesn't have the systemic and local complications that you have with barotrauma to the tympanic membrane with rupture. And we did rupture some tympanic membranes with hyperbaric when we were using it, where you don't have the problems with tension pneumothorax with rupturing blebs on the lungs, and you don't have the problems with hypoglycemia with the systemic complications with hyperbaric oxygen. So we are not using it for VLUs. For hyperbaric oxygen, we're using topical.
Tom?
Sorry.
Tom?
I think the hyperbaric oxygen obviously has a real role. I see this as not so much overlapping though this. I think the beauty of this that's very unique is the compression that's happening at the same time, I understand, right, Joanne? So
what I was about to try to add was that the big difference between hyperbaric and this therapy is that the tissue levels and sustainability of the oxygen levels in the wound center is better with this than it is with the hyperbaric.
I had a
Interesting.
question though, Joanne, about smoking, because in the VA, for better or worse, probably for worse, there's a lot of smokers, as we know, right, in the VA population. And
Yes.
and it would be really interesting to look at the cohort who smokes and whether that impacts the oxygen, or maybe those are better served, or is there a difference there? Are we able to look at that?
We have not analyzed that.
It'd be very interesting because that obviously has important downstream effects with oxygen delivery, et cetera.
That's a good point. Tom, you're involved with compression devices. Where are we with just compression?
Well, I mean, the problem with compression devices, as I see, is compliance. You know, there's a bunch of compression devices, especially pneumatic compression devices, but as important as they are, if they're not being used, then right. So I'm always very interested in patient adherence, and this goes to this device too. In other words, are patients using it? I think that when they have pain, which Anil mentioned as a positive effect, that they have less pain, you're really going to have a lot of compliance and adherence, I'm sure. But with compression, I think the more we can get away from, the more we can get towards patients using those compression devices, the more effective they are. A lot of the non-pneumatic compression, since you bring it up, are, I think, very exciting because they allow patients to exercise and walk around. And we didn't talk about that today, but the calf pump as an adjunct here, when people exercise, that's why patients sometimes do better when they're walking around. So if we can help patients exercise, I think that's an important, unmet need for this therapy.
Thank you, Tom. You went exactly where I wanted you to go. Parting shots, Joanne and Anil. Joanne?
Again, this has been a revolution for our chronic wound patients, and the compliance, and again, the pain scores going down around 2 weeks with the edema control has, again, stimulated patients to really be involved and invested in this and take ownership of their wounds and have helped successfully heal and sustain the healing.
Thank you. Anil?
And to agree with what Dr. Lohr was saying, that it's a useful adjunct and it really can help. As we said, we started with patients who we tried everything and we had positive results. So now we're using it on patients who were using it much earlier, and we're trying to liberalize it. But you still have to follow the guidelines in terms of they have to be wounds that you've tried everything and you've already had standard of care met.
Tom?
Yeah, I think that this is exciting stuff. I think it's got a lot of potential. I think there's some hurdles, obviously, regulatory and insurance and coverage, but I think it's it's important, and I think it's great research.
Well, thank you, Dr. Lohr. Thank you, Dr. Hingorani, and thank you, Dr. Maldonado. Next week, we are going to talk about something completely different. We're going to talk about cosmetic venous intervention through case discussions. And Demetrius Kantothanasis will be the speaker. Claudine Hamill-Desnos, Satish Vayavaglia, Luca Palumbi, and Elise Rodriguez will be our discussants. So we look forward to seeing you. Again, thank you very much. This was really interesting, and we have a lot more to explore. So have a good day.
Thank you.
It's a lot.